Good afternoon, everyone. I'm Hazel Cheeseman. I'm Director of Policy at Action on Smoking and Health. And thank you for joining us this afternoon for this webinar on local maternity systems and the opportunities around smoking in pregnancy. We're delighted to have so many of you on the line today. And this is the first of a series of webinars, and I'll quickly introduce the other webinars that we have coming up over the next few weeks. So just a bit of housekeeping before we get stuck into the meat of the presentations. If you're experiencing any technical problems during the webinar, you can use the chat function on the panel on the right-hand side of your screen to let us know. And my colleagues John and Vicky will seek to address any problems that you have. We're going to have questions at the end of all of the presentations, but if you have questions as we're going, please use the question function, which is also on that right-hand bar, to put your questions in, and as they occur to you, we might put some of them to the speakers at the end of each presentation, but the majority of those we'll take at the end of the Q&A session with the whole panel. And we're recording the webinar, and it will go online, and you'll be able to share it with colleagues and others who you think might find it interesting. So this is just to remind me to tell you that you can use the question bar. Please feel free to put lots and lots of questions on that sidebar, and if we don't get to answer them all, we'll certainly circulate answers after the webinar. So before we hand over to Em, who is our first speaker, I just wanted to do a quick introduction to the Smoking and Pregnancy Challenge Group. So this is us with all of our logos. We were founded in about 2012 with following a challenge from the then Public Health Minister to look at what more could be done to reduce rates of smoking in pregnancy. So we brought this large coalition together of organisations who were working in maternity and baby charities and academia and different professional groups. And over time, we've produced a series of policy reports, which are all available to download from our website, and I'll give the web address at the end of the slides. So we've produced these high-level reports sort of calling for change at national and local level on policy, but we really haven't stopped there. We've really wanted to provide support to people who are out there delivering interventions to support women with the tools that they need to be able to do their job most effectively. So we've got a range of resources which are on our website, which can help do that. So we have some training resources, and I'm not going to talk about this in a lot of detail. You can go and have a look yourselves. So we've got this very handy 2-page reference guide on implementing training locally, which I'd urge you to have a look at, and it's got some supporting infographics and animations that can be used locally. And it also, on the webpage, links to all the other training resources which are out there from the National Centre for Smoking Cessation and Training and other places where you can get high-quality training materials to support people around smoking and pregnancy. We've also got various aids to practice, and many of these are available. Hard copies are available, and if you get in touch with us, then we can make sure that we can get you those hard copies sent to you locally. So we have these cards which can be given to pregnant women to explain what carbon monoxide screening is, and then the accompanying advice for healthcare professionals as well. We've got a set of resources around e-cigarettes, which we're also currently updating. And these are all available to be either downloaded from the website, but also hard copies we can have sent to you. And we've also got this much less exciting looking document, but very useful document, which has a set of key messages around smoking and pregnancy, and also links to lots of the important evidence around smoking and pregnancy. And you can see from this page here that information is split up for messages that are for our technical professional audience, and then also how to reframe those messages for a more lay audience. It's a very handy document, if not a very glamorous one. And then the final thing I just wanted to let people know about. So we have likely you have heard about this webinar through the newly established Smoke-Free Pregnancy Information Network. So our intention is to do monthly updates through this network and updating people on current practice and research and policy developments that relate to smoking and pregnancy that we think can support you locally. So if you have a colleague that you think you should be opted into this network, then let us know and we'll add them in. Or if you yourself don't think you're part of it, then let us know and we'll also add you to that mailing list. And one of the first things that has gone out is this briefing, this tailored briefing that we've done for each local maternity system. And again, if you haven't seen the one for your local maternity system, then get in touch and we will send it to you. And the final thing I was going to flag is a new programme that we'll be launching in the next few weeks to recruit people very much at trust level who are already working around smoking and pregnancy, but might benefit from having being part of a wider network in relation to smoking and pregnancy. So we're calling them the Smoke-Free Pregnancy Champions, and we really want to make sure that we're communicating with them and giving them all the support that they need to be able to play their role fully locally, and giving them the information to act as a conduit for information for local stakeholders. So that's all I'm going to say about the Smoking and Pregnancy Challenge Group. I hope that was helpful. But now we're going to go into much more interesting presentations. Next slide, just remind me to say that the other webinars that I've got coming up, we'll have this slide again at the end of the webinar to remind you that there are these other events coming up. So we have an event on a webinar on nicotine in pregnancy, which is on the 8th of March, and one on incentive schemes, which is the 28th of March, and another one on health visiting, which we have the date yet to be scheduled. And we're also planning to have some conferences, regional conferences later this year. We'll make sure we circulate this information as well so that you have it. So I'd like to move on to our first speaker, Irving, who's the Programme Manager for Prevention and Maternity for West Yorkshire and Harrogate Healthcare Partnership. Em's going to be talking to us about the work that's been done by West Yorkshire and Harrogate Local Maternity System to reduce smoking and pregnancy, and I'll hand over to you, Em.
Thanks. Can everybody see my screen? I just want to make sure it's worked at this side.
We can see it.
Excellent, brilliant. So good afternoon, everybody. As it says on the slide, I'm the Manager for Prevention and Maternity for Public Health in West Yorkshire Harrogate and West Yorkshire Harrogate Local Maternity System. I have two hats in the Healthcare Partnership in West Yorkshire and Harrogate. I am the Public Health Lead for the Local Maternity System, but as I'll go into a little bit more detail later on, I also have another side to my post where I am the Manager for Prevention at Scale for the Healthcare Partnership in its totality. So this afternoon I just wanted to go through the background of the work we've done in West Yorkshire and Harrogate, and that work was done at a Yorkshire and Humber level. Talk about the key outputs, how this has enabled the West Yorkshire Harrogate Local Maternity System approach, and what our next steps are for taking this work forward. We're a very big local maternity system. We have 6 acute trusts, 11 CCGs, 233 GP practices, 3 community providers and 4 community and mental health trusts. So as you can imagine, it's a big task for our local maternity system to get our partners together and agree to take work forward, a task that's been done really well. We have really good cooperation from all the partner organisations. The beginning of the smoking and pregnancy work was done across Yorkshire and the Humber, and that was led by myself in my previous role with the Clinical Network for Maternity and by the Public Health Lead, Scott Crosby. And what we did was initially in 2017, we held a symposium in Leeds and brought together all the great and the good to look at what can we do, what are the challenges, what are the barriers, what are the opportunities in relation to smoking and pregnancy. This had attendance of about 100 delegates or more and brought together providers, commissioners, public health leads, midwives. And what the output was from this event was, how do we then take this forward on a local maternity system level, and can we develop a draft pathway for Yorkshire and the Humber? So that was taken forward in some workshops that were held in May and September in 2018, again across the Yorkshire and the Humber footprint. As part of that work, the aim was to look at how do we reduce variation and improve outcomes, but offer a service that's appropriate to the population and the needs of population at place. So we came up with a very generic, based on nice guidance, based on evidence and good practice that's already existing around the region, a pathway for smoking in pregnancy. At the second workshop in September, All these people came together again with the Public Health National Lead and looked at the pathway, but also tried to then look at what does that mean for a local maternity system. So from that, we also developed a local maternity system journey for implementing smoking in pregnancy and touch points across the whole pathway from preconception right through to early years. So I will show you those tools in just a second. This initial work with Yorkshire and the Humber has really helped establish partnership working across West Yorkshire and Harrogate. So the group that was meeting as part of the Yorkshire and the Humber work is now coming together to look at how do we implement the outputs from that Yorkshire and the Humber work. It's also brought together engagement from the trusts, public health, commissioners, both tobacco commissioners and children and maternity commissioners, so that we're all looking at the same thing and trying to achieve the same objectives. So I've mentioned we've developed a draft pathway, a touch point and an LMS journey. These have helped the local maternity system look at how do we audit what's currently going on in our patch. How do we know whether or not the services that we've already got in place are fit for purpose, are quality, and are meeting the needs of women and families? How are we identifying and celebrating success? And how are we sharing the barriers to success? One of our trusts in West Yorkshire and Harrogate in Mid-York, the Mid-Yorkshire Trust, has done a tremendous amount of work to bring their smoking rates down. And we look at what they're doing and we share that practice across the local maternity system. This is the LMS journey. I don't expect people to be able to read that because it's very small, because it's a big document, but I will provide it for circulation after the WebEx. It looks at from booking appointments right through to after birth. The whole point of the pathway across West Yorkshire and Harrogate and Yorkshire and the Humber is that we start and we try and start from preconception, which goes into the other side of my role and looks at population, reducing tobacco and smoking in the population. So women aren't smoking in the first place, right through to early years, and how can we continue with smoke-free homes? So we are pushing the boundaries ever so slightly in West Yorkshire and Harrogate, that we are dipping into absolute preconception population prevention work, and we're going a little bit further with our postnatal work into early years. These are the touch points. So we looked at them, as I said, from preconception. The touch points looked at what's the bare minimum. If we were to have a service in every area, what would be the bare minimum provision at each of these touch points? So you've got school nurses, sexual health services, fertility clinics, family centres and early years centres, secondary, tertiary settings, primary settings, community midwives and maternity voice partnerships. So what's the bare minimum? What would good look like? And what would excellent look like? What we didn't want to do was be too prescriptive, because one service won't be the same in one place as it is in another. It has to be bespoke and tailored to the needs of women and families in that particular place. But we can get the fundamentals, the foundations and the basics right, so that every woman has access to the same consistency of service. The next part of the touch points tool is to look at the intrapartum element of the pathway. So where are the touch points within this pathway? If you've got a home birth, birth centre or a hospital-led birth, and again to look at their minimum, good and excellent. And obviously we're looking at continuity of carer and how that's going to impact on smoking in pregnancy and women who are smokers. Again, you might not be able to read all the detail in that, but I will send it out. Postnatal and early years is the final element of the touch points. So that's looking at straight after birth, transition from maternity to health visiting, looking at the discharge again from community midwives, first postnatal contacts at home, where baby remains on the neonatal unit, first visit and transfer, 6-week postnatal check, etc., right through to early years, and where health visiting continue their visits. And again, it's bare minimum, good and excellent. This is the final tool that we produce as part of the Yorkshire and Humber work, and this is the smoking in pregnancy pathway. Now, we had lots of discussions when we were developing this on what the CEO level would be for referral, and we decided to go with 4 and greater than 4. So any woman that is 4 or greater than 4 would be automatically referred to smoking cessation services. So how are we now taking this forward as part of the local maternity system? We have, as part of our local maternity system, a very robust health needs assessment that was undertaken by Public Health. It's actually just about to be refreshed. That health needs assessment identifies where there may be health inequalities or wider determinants within our patch that impact on why women continue to smoke during pregnancy or are barriers as to why women are unable to stop. We also have an equality impact assessment, and we've got a public health consultant sat on our local maternity system board. So public health is very much embedded from board level right through to our prevention task and finish group. We've also got an LMS prevention steering group and programme, and then there's myself in post as the public health lead. As part of the job when I first came into post in West Yorkshire and Harrogate, I did a lot of scoping around place, both with public health teams within the local authority and with all the public health and specialist midwives within our trust. So I went to visit every single place, every single trust to find out around the whole remit of prevention, but obviously smoking pregnancy was a large element of that, to look at what the good practice already is that exists, to find out what keeps them awake at night, to find out any ideas that they've got for future service and transformation. And we've collated that scoping together, and that's now informing the work programme going forward. We're also part of the West Yorkshire and Harrogate Tobacco Strategy Group, and as my role as a prevention at scale lead, I sit on that group, and I've been able to get smoking in pregnancy embedded in there as a standard agenda item. So not only is it being looked at as part of the local maternity system group, but it's also being looked at across the whole of West Yorkshire ICS, the integrated healthcare system. We also have a prevention at scale work programme for the integrated care system. So I am the manager for that programme, and I embed everything around my maternity programme into that area of work. So we've got a whole population approach to smoking in pregnancy, as well as the bespoke needs of maternity. So our next steps are to take this work forward and really start to tackle the issue of smoking in pregnancy across the local maternity system. So as I've mentioned, we've got a prevention steering group with a governance structure into our local maternity system, but also into local authorities at play. We've got a smoking in pregnancy task and finish group, which is about to be launched in June, and we've got the LMS plan and trajectories for prevention. This is the prevention governance going forward for the LMS. The steering group is made up of a public health lead from all places, so all 6 local authorities have a public health lead on this group. We have a public health midwife, an LMS senior midwife, a data analyst. We've got primary care representation and NICE representation also on this prevention group. We have 9 task and finish groups coming from this group, smoking in pregnancy being one of the first to be launched, and you can see the remainder of them on there. And then we've got public health at play. So this is how we feed in and are accountable not just to the local maternity system, but also to the integrated care system. So the prevention steering group, which hosts the smoking in pregnancy task and finish group, directly feeds into our local maternity system board, which in turn directly feeds into our system oversight and assurance group for the healthcare partnership. It also directly feeds into governance systems at place. We've got a dotted line to what is our implementation group. The implementation group is made up of commissioners, consultants, midwives, heads of midwifery, and the LMS team. And they will have an oversight and a line of sight into the work that we're doing in prevention to make sure that anything we're doing in the smoking in pregnancy task and finish group is linked to where there are interdependencies in, for example, the safer maternity care task and finish group. So the task and finish group is going to provide a coordinated approach between and within partner organisations, and that's already established. We have those partners there ready and waiting to go, built on the work that that have taken place at a Yorkshire and Humber level. They're going to be influencing the plans and the work programmes of partner organisations. We see that predominantly the majority of this work is going to be done in the wider system. So although there is an ask and a need for smoking in pregnancy to be tackled within trusts, within maternity services, we're very much aware this is much bigger and it's out there in the public health services, health visiting and primary care. We want to promote a forum for dissemination and promotion of best practice. We don't want to reinvent any wheels. If something's already working, then we want to build on that. We have a real variety across our system on how smoking cessation services are provided. So not all of our places and our public health teams commission stop smoking services. Some of them do it through direct contracting with primary care, which includes pharmacies and GPs. So it's very different. So we need that task and finish group to have an oversight of all those different services to ensure that women are getting that consistency of quality and access. We want them to advise on the delivery and development of practice and purpose and propose improvements and recommendations for service delivery. Because we're embedding the governance of the prevention steering group in local authority governance systems, we'll have more buy-in and opportunities to influence those grassroots services at a public health level. It's to provide an environment where problems of common interest can be discussed. One of the biggest things that I've found through the scoping of smoking pregnancy, particularly with our public health midwives, is there's lots going on. This work's been going on for a long time. It's well established in places, but actually commissioning arrangements might be different. Resource and funding might be different. So we want it to be an environment where people can bring those different topics and problems, and we look at how we can address them together as a system. We want to oversee the implementation of the regional best practice pathway, so that's the Yorkshire and Humber best practice pathway, but we will have a big drive on reducing health inequalities within smoking and pregnancy and identifying and influencing the wider determinants that impact on women and families smoking or stopping smoking. As I touched on, that's the partners within our prevention steering group and our task and finish group. So we're trying to be as broad as we can with the people that we're getting around the table. This work is driven by public health leads, not by maternity services. We will be having a separate public health midwife virtual network that can feed in, and the chair of that group will be on the steering group for prevention. But we were very keen that this needed to be driven and owned by public health. And we'll be inviting specific professionals to engage with us as appropriate. So like everybody else, we've got the national target of reducing smoking to 6%. And our wonderful data analyst has looked at what that means in numbers for the local maternity system in West Yorkshire and Harrogate. So as you can see, everybody now wants to move to Harrogate because their number needs to reduce by 1 if we're all going to proportionally reduce by 1% each year to achieve the target of the system. This breakdown is one way that the target can be achieved by each trust and each place reducing their proportion each year by 1%. There are other ways to break that down that our analyst has been looking at, and we're going to agree as a task and finish group which one we decide to take forward. And that's it, really. That's the work that's been done in West Yorkshire and Harrogate.
Thanks, Em. Like we need another reason to want to move to Harrogate, I would say. It's a lovely place. We're going to hand over to Andrea Crossfield from Greater Manchester shortly. So, Andrea, get ready for us to share your screen with the rest of the webinar. I just wanted to ask you, Em, before we move on to Andrea, you know, the work that's been done on these pathways at regional level is it's so interesting. What do you think the biggest challenge is in bringing that sort of high level work down to the level of practice?
Capacity is always going to be the biggest challenge. Whether you're doing something across a region or you're doing something at a local maternity system level. So I think our biggest challenge is that we've got the tools, we've got the information now, thanks to the work that's been ongoing, but it's actually capacity within our public health teams as well as our maternity services to actually start to implement the changes that we put forward.
Yeah. I suspect that might be a theme that comes up. I'll just remind people that you can we'll take some more questions for Em and for the rest of the panel at the end of the webinar. You can put your questions in the bar on the right hand side of your screen, and we can see them here at this end, but the rest of the group won't be able to see them until I ask them at the end. So do feel free to ask questions. All right, I'm now going to hand over to Andrea Crossfield, who's the Making Smoking History Strategic Lead for Greater Manchester. And we're really grateful to Andrea for stepping in at the last minute, as unfortunately Jane Coyne was not able to join us today. So Andrea is going to talk us through what's happening at GM level to support smoke-free pregnancies. Thanks, Andrea.
Hi there, everybody, and sorry that Jane can't be with us today. I know she would have loved to have been here to answer your questions and talk about her huge passion, which is delivering smoke-free babies in Greater Manchester. So our work is part of around smoke-free pregnancy, as part of that broader programme of work around making smoking history here in Greater Manchester. And we're delivering that as part of our broader strategy through our GM Power model, based on the WHO Empower model, which you'll all be very familiar with. And we just added a G for growing a social movement for a tobacco-free Greater Manchester. Oh, I can't seem to move my slides on. Why is that?
Andrea, that won't be at our end, that'll be at your end. Do we have your slides? I think we have your slides, don't we? What we'll do is we'll put them up on, Andrea, we'll put your slides up on our screen and we'll move them forward for you to make life a bit easier.
It's all right, move now. It's okay.
Excellent, good.
So move for everybody else, I assume, as well. Sorry about that. So it's part of our pregnancy programme is already now starting to transform our maternity pathway, deliver some of those smoke-free pregnancies and families. We've so far, up until the end of January, had an additional 633 women quit through the incentive scheme, but it's about how the whole programme works together. So that in our first 12 months following implementation, we're hoping to deliver an additional 1,200 babies. But as I've said, it's part of that bigger picture of delivering a smoke-free generation. But where are we in terms of delivering our ambition? We want to get to 6% of women smoking at time of delivery by 2021, and I'm just putting this slide up to show you how far we have to go in a really short time. So here are the localities within Greater Manchester, the 10 localities, framed top and bottom by our best area within the country at the moment, or at the point when we kind of started the programme. In terms of smoking at time of delivery data, Westminster in central London had the lowest smoking at time of delivery rate, and Blackpool here in the northwest, in spite of really great progress and really good learning for us here in GM, had the highest smoking at time of delivery rate. So you can see that there is quite a bit of variation within Greater Manchester, and overall our smoking at time of delivery rate is around, at our start point, was around 12%. But we're not just saying that we want to get to 6% overall. We want to have every locality at no more than 6% by 2021. And in so many meetings, in so many forums, what everyone is saying is that we want every baby to be born smoke-free. So that's the aspiration, that's the vision. How we achieve that is much more challenging, but that's clearly where we want to get to. And how we achieve that, really, when we think about that, when we recognise that particularly up here in the north, and in Greater Manchester, we've got an awful lot of younger mums who are smoking during pregnancy, and in terms of how we tackle those inequalities, there is a lot that the wider programme of work that we're doing to reduce smoking at population level down to 13% by 2021 and to less than 5% by 2027 can do to help us to achieve that. So the programme itself is in two parts that are absolutely intertwined. So that system-wide programme of support to treat tobacco addiction in pregnancy, delivered through the evidence-based Baby Clear model, and that's part of a GM-wide, system-wide guideline, and evidence-based support to systematise and embed that organisational change within the pathway in line with NICE guidance and the Saving Babies' Lives Care Bundle recommendations. We have the unique risk perception intervention that's part of Baby Clear for those women who are continuing to smoke at their booking scan. And as part of this, we've got a whole set of KPIs that we're now delivering, including smoking at time of booking data and 36-week smoking data, which is really helping us to track where we are in terms of those women who are quitting without stop smoking support intervention, which we know Baby Clear generates a fair few of those. The second part of the programme is joining up Baby Clear with incentives at scale. So anyone who we perceive to be vulnerable and in need of incentives gets incentives. There's no limit on the number of women who can have incentives to support their quit attempt through pregnancy and beyond pregnancy. So for previous Greater Manchester schemes which were evaluated, we saw around 70% of women achieving a 4-week quit, 70% of those women who achieved that 4-week quit still quit at delivery, and around 50% of those still quit at 12 weeks postpartum. And they were rewarded and are still continuing to be rewarded with Love to Shop vouchers. So that's the scheme that we have in place now is very similar, but we're rewarding women now either up to 12 weeks or to 12 months postpartum. And I'll talk a little bit more in a few minutes about the fact that we have a randomised control trial now in place to understand how that's working. So in terms of early outcomes, we've seen a significant increase in CO screening as per the pathway. So we're now at a 90% average across our trusts, which is still not where we'd like to be. The KPI is 95%. Obviously, we'd like to be at 100%, but those who might tell us that they will be at 100%, we wouldn't necessarily believe anyway. So that's where we are, and we're working our way upwards. We've seen a 36% increase in referrals to stop smoking services. I've mentioned in the kind of numbers of women who are coming through onto the incentive scheme, and we've got really good uptake and engagement with that. In terms of our CO validated 4-week quit rates for pregnant women, our average across Greater Manchester now is 55%. We've got a lot of new specialists supporting pregnant women to quit. We've got a lot of new maternity support workers in the system, and so I think given where we are, that's really great. And where we've got specialist midwives and maternity support workers working together within a hospital system, our average 4-week quit rate CO validated is 70%, and that compares with Northwest 4-week quit rate in pregnancy of 26%. So we feel like we're definitely heading in the right direction there, and that we've got scope to improve further. So we have put a randomised control trial in place, which will help to support us understanding the impact of those postpartum incentives in preventing relapse and the promotion of further smoke-free pregnancies. We do want to support women to stay quit but we need to understand the effectiveness of those postpartum incentives, because we know from the tap-in pregnancy incentive scheme that their 3-month quit rate postpartum was quite similar to that in our incentive scheme, and they weren't continuing to incentivise. So we need to understand what the value and impact of continuing to incentivise postpartum is, and what the right point to do that to is. In terms of challenges and learning, I think that obviously with an intervention at this scale, we have really needed to recognise that doing things in a phased way has been really valuable. Early engagement with locality leads has been really important, and really it's been about relationships, as these things always are, in achieving the best results. IT has probably been one of our biggest challenges, as perhaps it often is in the NHS, and robust data collection is so important in knowing where you are, and I think some challenges remain for us there. Most of the issues that we've had have been resolved through system-wide approaches. So I think bringing people together regularly, both within the clusters and across clusters, has been really important. The specialist midwife roles, I think, have been critical in supporting midwifery support workers, providing mentoring, engagement and support for them, and the recruitment and induction and support of those staff has been key. We have had some real issues around NRT provision, particularly for non-registered staff. I would say that that's not just an issue for us in Greater Manchester, probably a national issue, and there's still some, we have resolved those for now, but I don't think the things that we've put in place are perfect, and it would be great if midwifery support workers were able to go into women's homes and provide NRT to them at home. We haven't found a way around that, and we would really like to find a way around that. The maternity support workers themselves are really valued by the women who that they are supporting. You can see that from some of the qualitative evaluation that's been done, early qualitative evaluation that's been done with women around their roles, and they are absolutely fantastic and loving the work that they're doing with women. As I've said, we've got 3 UKC universities involved in the evaluation work, and there's a whole range of evaluation that's going on to look at the impact of the programme on health indicators, the evaluation of the risk perception to understand its impact on quitting behaviours, the RCT, which I've mentioned, also some wider qualitative evaluation around the acceptability of interventions, not just with women, but also with family members, looking at the wider impact of the programme on smoking behaviours, including smoking in the home, and also looking at inequalities and the impact of incentivising quitting on health inequalities. So whilst the final evaluation data won't be published until probably quite late in 2022, there will be a number of papers that will be published probably earlier in 2021. So that's my presentation. Unfortunately, I'm not able to stay for the panel discussion, but I am really happy to take any questions now.
Thanks, Andrea. That was excellent, and I'm really grateful to you for stepping in at the last minute. There are a few questions. We might not have time to take them all, but there's a specific question around how you got CCGs to engage in this work.
So the way that we developed the programme initially was through taking forward the business case for the work with the system across Greater Manchester. So certainly we have it's a little bit different now, but at that time we had an association of CCGs across Greater Manchester, and we took a paper to that organisation and had some discussion with them about, what should the scale of ambition be, and certainly in that forum, in terms of the kind of chairs, chief officer level people within CCGs felt that we should be looking at every baby born smoke free. So I think that when you get to the kind of how are we going to deliver this, you start to have slightly different conversations about what your KPI should be and how you'll do it. But I think getting that senior level sign off was absolutely critical, and making the case for the return on investment that the programme could deliver. And we had, so we had directors of finance from CCGs, for example, involved in signing off the business case.
Thanks, Andrea. We've a few questions about the incentives work as well, but as I said at the beginning of the webinar, we have a session on the 28th of March on incentives. So we'll encourage people to attend that session to talk in more detail about incentives then. And we're also producing a briefing which Jane is helping us with, Andrea, on incentive schemes in pregnancy, that will be published around the same time as the webinar. So we'll probably pick up the specifics on incentives later in the month. There was a question which I think we'll probably come back to in the panel as well, because I think it comes up a lot, which is around sort of sustaining the engagement, that the challenge that people face is not necessarily in making the referral, but in ensuring that women take up the offer. Would you have any further thoughts on that?
So sustaining the engagement with the woman?
With the woman, making sure that she goes to the stop smoking support when it's provided.
So whether or not women are receiving incentives, women are being offered support throughout their pregnancy, right up until birth. And, I guess, for many of the women who continue to smoke in pregnancy, they will fall into that vulnerable category. So in Greater Manchester, for those women who are engaging with services, many of them are eligible for the incentive scheme. So whilst women often say that the incentives aren't important, they do keep women coming back. And I think that is really important for us to remember about what will keep someone coming back to an appointment. But I do think that, keeping that relationship going over that 9 month, or it will not be a 9 month period, but perhaps kind of at least 6 months, keeping that CO monitoring as part of that process, and also offering home visits is I think is really important. Going to where women are, and the fact that advisors are just kind of on the end of a phone, texting women, building the relationship throughout the pregnancy. And, midwifery support workers can be really well placed to do that. And, where we've got that kind of maternity system based model in place, that is working really well for us.
Brilliant. Thanks, Andrea. And again, really appreciate you joining us for the webinar, and understand that you can't stay with us to the panel. We're going to move on now to Becca Scott. But before I move on to Becca, there was a comment that's come through from Claire. I think you're embarking, Claire, and you've said that you've done really well over the last 3 months in your area around carbon monoxide screening, and that you have basically got 100%. If you could share some more information during the next bit about how you've achieved that, that would be really interesting. So we'll move on to Becca, and Becca is the Regional Local Maternity Systems Prevention Coordinator, I'm going to say across the North East, as there are lots of areas which Becca covers. And Becca's going to talk to us about the work which is happening in the North East. Thanks, Becca.
Hello, good afternoon, everybody. So, as Hazel said, I'm Becca Scott. I'm the Regional Local Maternity System Prevention Coordinator, and I cover the area in the North East, which, if I can change, I'm having the same issues as Andrea. Get the next.
Oh, are you having a problem with your slides there?
Mm-hmm.
Do you want us to take them through the slides, or are you?
Give it another little go. Oh, it's working now.
Here we go. You seem to be up and running.
Yeah, we're working again. Okay.
So never these things without a hitch.
I know. So as you can see from the map, it's the bluey and the orange kind of coloured areas. So we borders of Scotland, right down the east coast, tipping into North Yorkshire, and coming up there, the west, just bordering on to Cumbria, but Cumbria is a different LMS area. So that's a little bit about our structure there. So with the LMS prevention work, it's one part of, obviously, the LMS agenda, and the prevention team consists of a Director of Public Health, a consultant in public health, myself, and we do have a couple of members of staff that support us in that as well. And the whole purpose of the work is to have a particular focus around prevention in maternity services, which ultimately tips into other professions. And with this, we haven't got a particular budget. We're about utilising what we already have. We have some excellent resources available from places like yourselves, Public Health England, and it's about utilising that. We're really keen to make every contact count in maternity. Maternity services is a very busy service, so we just want public health just to be part of that routine work. And I'm really there to troubleshoot and navigate through the maternity system. I'm quite accessible. I do try and get to as many local events as well as regional events. And part of my role updates the stakeholders and monitors the progress that we're making. As I said, it is a large area and it does cover 13 local authorities, 8 maternity NHS trusts, and I think it's about 10 CCGs, so it's quite complex. So the 7 areas that we looked at for prevention are just on the screen there in front of you. But obviously the ones that we're really keen about, and the one that we have right at the top as our priority, is smoking in pregnancy. And we're really keen to go further than the ambition of 5% by 2022, because we want to have 5% by 2025 and 10% by 2020. So we're really keen to go a bit further instead than that 6% ambition nationally. So just lots of people know this already, but we have such a huge smoking issue in our general population in the North East. It's around 16.2% of adult smokers, and it's responsible for 17% of all the deaths of people aged 35 and above. There's massive cost implications to society and our NHS, and it's the biggest modifiable risk factor, particularly to pregnancy outcomes. So nationally, there is around 65,000 babies born to mothers who smoke every year, and I'm sure you know, but there's a few details on the screen there of what a smoking mother can have, what effect that can have on the baby. So smoking is actually strongly correlated to deprivation, and as you can see in the northeast of England, we do have quite a lot of deprived areas, but that isn't to say that's the only reason that people are smoking. We also have quite a static population in the northeast, and we do look at some of our other LMS areas, and sometimes it's about behaviour and culture and the way that families live, and that's part of their normality. So looking at our current positions, these are the areas that we cover. You can see we've got quite a long way to go. Our highest rates of smoking are through the Durham and Dales, Easington, Sedgefield area. There's lots of work happening there, which I'll get to in a moment. But we do have quite a way to go to get down to those ambitions, as you can see. So when we started this work just before summer last year, there was an audit completed for the region's maternity unit, and that was benchmarked against NICE guidance. And there was quite a lot of findings there that really has informed the work that we've been doing since. So the key recommendations were about having a regional pathway that needs to be in line with NICE guidance and best practice. As we were aware, there was Baby Clear launched in the area in 2012. It had a big impact. There was lots of good work done. However, it was viewed a bit as maybe as a project. This seems to be a finding from the audit that it wasn't really embedded. And once the emphasis went away from Baby Clear, that actually we weren't 100% sure whether those pathways were still being followed. And as we got the information back from the unit, it did look like practices had changed away from what had been trained. So it's about bringing that back together through a refreshed pathway. We're really keen that maternity units actually have ownership over the smoking in pregnancy. It's not something that's being done to them by local authority or nationally. It's something that they're taking ownership of. It's actually a medical condition. It's tobacco dependency, and it's about supporting that woman just as she would be supported with glucose in a urine. It's part of routine care. We also want to make sure that the training is kept on the agenda, so that it's mandated, that it's annual, that it's current. A big thing that we uncovered through the audit was around e-cigarettes and vaping and misconceptions. So we've been doing a lot of work to dispel those myths and really improve access and encouragement of those devices. We really want to utilise the materials that we've already got available to us. But again, maternity is extremely busy, so it's making those available to them in a more accessible way. So we're devising something called a virtual training hub for our region, and that'll have access for midwives to look at a certain subject of the prevention agenda and see what they're meant to be trained, how often it's meant to be refreshed, who should be providing it, just so there's some consistency. And this will definitely benefit mums and families coming through the services as well. We really need to make sure that the data we're collecting is really accurate and that it's appropriate. Again, that was uncovered because not all units are using fully electronic systems. So they are developing as part of the bigger LMS work, but we're needing to really support that and encourage that we have a bare minimum. So again, just similar to the other areas, that all women are screened for CO at booking and at 36 weeks or delivery if they deliver earlier. And that should be as a minimum standard, which will be embedded in the pathway that we're developing in the region. We need to make sure we've got robust governance processes to validate our data, to have it analysed, report it. We want to make sure we communicate it back out. If midwives and maternity care assistants are doing really, really good work, we want to feed back to them that they're making a difference, because sometimes it's hard to know as a practitioner what effect you're having. So we're really keen for them to know that they're having a really good impact. And we also need to look at our equipment as well, because part of Baby Clear, it does state that maternity services are now responsible for maintaining those monitors and replacing any CO monitors. So we're keen to really embed that as well. We would like the smoking in pregnancy to be an agenda wherever we can, and particularly around trust clinical safety forums and part of maternity, to make sure that that risk factor is always looked at in the case of adverse outcomes as well. We want to promote the public health agenda from a wider trust perspective and including maternity into that. We want to make sure the services are all collaborating and that we have a real good partnership agreement locally. We've got to make sure that there's leadership there in these maternity services that we're asking to really run with this, because, as I said in the past, it hasn't been embedded, and sometimes it's down to job roles, or sometimes it's been that it's been not particularly anybody's responsibility. So again, we're kind of engaging with champions and lead professionals or public health midwives. And I think I've covered those other two bits. So from the recommendations and the audit, we had an event back in October. We shared the audit, the recommendations. We had localities sat together, and on those tables we had local authorities, CCGs, smoking services, midwives from various backgrounds, health visitors, early years, a variety of professionals. And we really looked at how could you embed this into your practice and what would you foresee as the barriers. We also then had a maternity focus group to really look at what we could do to put this into practice. We've took all this information onto our regional tobacco dependency commissioners and shared the work that we were doing, because we recognise that it isn't just maternity's job, it's about everyone working together and trying to influence for the practices to work really well. We had a regional director strategy meeting, which is now called a programme development meeting, and that looks at how we delivering this work at a strategy level. We have developed about data collection, so now we're at the stage where we're working with our North East Clinical Network about collecting data regionally as well as to the CCGs, and then we're looking at doing some deep dives actually with the trust to see how we can really improve that at trust level. And again, that comes down to they all using different systems, so it's really difficult to get systems to talk to each other. We've also started a regional group which is looking at developing the pathway, and again that's multi-professionals and looking at practice areas as well that are coming up. So for example, a serial scan pathway for smokers. There's nothing at the moment that says that has to take part, that has to happen, or when it should happen. So again, it's about those discussions and see how we can develop it further. As part of the work, we also did a red, amber, green rating out of the current services that we provide, which you can see there in front of you. So it just gives you a rough idea. It's not set in stone, and we are definitely moving forward with it, but it's just to give us an idea of what can we improve in our area. As you can quite clearly see there, we need to have some sort of script because the practices were quite different across the region. We would have some areas asking women, do you smoke? They said no, so they didn't do a CO screening. And then we have some areas that do follow how they've been trained to the word, where they're doing the CO and it's part of that routine appointment at the very first contact. And then they're saying, actually, we're really worried about your smoking. And it's about medicalising the terminology and having a clear pathway of care for these women. And the partners as well, and that's another part that we're really working on in this area, that we really want to look at families, because we know the 67% more likely to quit and stay quit if the significant other also quits with them. So it's important that we don't forget that significant other person attending. So CO screening in sessions, as you can see, that's red, amber, because it's so different everywhere, and that can be down to individual practices. The way that they refer to specialist stop smoking services can be different, and that's sometimes just down to what services are actually available. We are lucky in the North East that actually we have some form of specialist stop smoking service available. Some of them are delivered in-house by maternity care assistants, and some pharmacies where there's a drop-in once a week. So it's a little bit different everywhere, but I'm sure that we can develop that further at a local level. And audit was another big area for us. Baby Clear said it kept it in focus when that stopped. The focus has gone away, so it's embedding this work to continue on. So the work really did kick off quite a lot of local work. So there's been multi-agency development groups. We've also had bespoke maternity public health plans looking at all 7 areas, and that's really improved partnership working. It's linked the policy to the practice gaps. It's making sure there's regular service reviews and that the governance happens. We we're allocated some health and social care funded places. We've, as I said, updated on vaping. We've got a firm opt-out approach to any stop smoking service, and we really want to make sure that happens quicker. So ideally, they get an appointment there and then while they're identified as a smoker. It's all the finer details, and as I said, that is delivered locally with each of the units through a maternity plan with all the professionals there around the table. We've also got a very good support from the integrated care system. They have chosen smoking in pregnancy as an area to really develop as part of a project with Yale University. And there's some interesting developments there to look at mindset and the way that we may be thinking about talking about smoking in pregnancy. So that should be really good. We're improving the way that we report, as I mentioned. We have the regional group, and we're really influencing other professionals as well. So we've started meeting with health visiting services and really asking them, could you continue the support on? So we focus on it a lot when they're pregnant. But once we hand over to the health visitor, yes, the health visitor most certainly do support with asking women to go to a stop smoking service. But what we would really like them to do is to continue that CO monitoring and that real strong support. And then obviously we're also gaining national support and local support. We're very well supported by Fresh, part of ASH. And it's just continuing that on, and we'd like to think it's a two-way process because we are working really hard up here in the North East, and we have got a long way to go, but we are making a good start. And that is a short version of what's happening. Has anyone got any questions for me?
Thanks, Becca. That was excellent. I have a question for you. Could you scroll back a bit to your slide with the RAG rating on, and with all the reds and yellows and greens?
Mm-hmm.
It struck me that looking at that, how important do you think consistency across the region is for sort of the overall outcomes for the North East? Because there's quite a lot of variation in practice, it would seem, from this slide. Is that something that you think is important to address?
It is, because I strongly believe that if you're a family asking for specialist support in Darlington, for example, at the south of our North East, or whether you're up in Northumberland on the borders of Scotland, you should roughly have the same service from primary care, and for all the specialist stop smoking advisor support services may differ. You should be still identified the same, and you should be still shown that it's a priority, that we need to make a difference, and that actually it's not normal to smoke, it's a dependency, and it's going to be a big effect on that baby as well as your own and your family's health. So consistency is really important, but I don't think it was until the audit's been done that we realised actually it's not just units across the region that differentiate, it's practices within those units.
Yeah. So audit for you
level.
As a recommendation then from what you've learned from your process would be for other areas to do a similar kind of audit would be quite illuminating by the sounds of it.
I would say so, yeah.
What somebody is asking, I think Michelle Littlejohn is asking whether other areas might have scripts that could be more widely shared. I would say if you do have a script that you think would fulfil that purpose, then let us know, and we'll definitely have a look and see what we can circulate. So Becca and I'm going to invite you to answer a few questions. I'm being asked to show my screen, which might not be. I need to look at the questions at the same time, so maybe one of you guys could put it on your screen. So I'm just going to give a bit of feedback because I asked Claire to tell us how she was getting such great carbon monoxide screening levels, and she has let us know. So she says that they've done this and I think a lot of this, I guess, is not rocket science. So we've managed to achieve this, Claire is saying, by training combined with incorporating the questions around smoking in carbon monoxide level in the electronic booking, and this question is mandatory, and there's room for free text to explain why it's not been done. So each month Claire receives data, and she can link back to the booking midwife, and it enables her to contact midwives and follow up the rationale for not performing the carbon monoxide screening and resolve those issues, and also make sure that they address things like not having spare batteries and so forth. And one of the most important things is that each midwife is carrying their own carbon monoxide monitor too, which yes, I know from personal experience, not having your own carbon monoxide monitor makes it difficult if there isn't one in the clinic. So yeah, and I guess that probably reflects the experiences, Becca and Em. If you want to get up the carbon monoxide rating, it seems training, making sure that people can populate things through the electronic booking, and that question is mandatory, and that feedback loop as well seems really, really important to practice. Would that reflect experiences in your regions?
Absolutely.
Claire?
I mean,
sorry, carry on.
Yeah. Yes, just absolutely. I was going to say that is part of each of the unit's plans, that they're having the field mandated at booking and at 36 weeks, so that they can't physically get through that screen unless it's in there, or there's a reason why not.
Great. So I've got some questions that related to other sort of feedback loops to frontline staff and how that might be achieved. I don't know if Em or Becca, you'd want to come in on how we feedback better within the system to practitioners about outcomes and what's happened next for their patient. Is that something that either of you have looked at?
In Yorkshire and Harrogate, we've got a comprehensive communications and engagement strategy. So it's been a big part of the initial work of Local Maternity Systems to ensure we've got mechanisms for feedback and mechanisms to alert staff to what's happening in maternity transformation, in local maternity systems, and specific work at task and finish group level. So we have a regular HOMS email that goes out every Thursday. We've got an LMS leaflet. The website's very robust and has a lot of information on there. We also have links with our healthcare partnership engagement lead, and they support us with delivering any sessions to staff to help them deliver feedback to women and families as well. And it's also part of the work of the Maternity Voice Partnership group that we have established for the local maternity system.
Thanks. We're going to have a go and see if we can unmute Hilary Waring from IPIP and ask her a question about baby clear. So we'll have a go and see if we can unmute you, Hilary. So we have a question about how, and I think this came up through the North East presentation as well as the GM one, about the sustainability of the baby clear model and how we can secure that. Sorry to put you on the spot when you just dialed in to listen to everybody, but I thought that you might have a good answer to that question, Hilary.
Yeah, can you hear me?
Yes, we can.
Okay. Well, I've got feedback, so I'll try. I think the way we first went into the North East, that wasn't something we knew an awful lot about. And as we're working in the Greater Manchester, then I'm just going to cover. I'm going to cover my hearing. See if I can.
It seems like Hilary, are you on a speakerphone? That might be the problem.
No, I'm not.
Oh well. I tell you what we'll do is we'll have a chat with you and we'll circulate your answer after the event because it's a bit difficult to hear you. So we've got 1 minute until we finish the presentation, and we've still got lots of questions that we've not answered, and I'm really sorry that we've not had time to get to them all. We will endeavour to provide some written responses to those questions that people have asked and we've not been able to answer, particularly around baby clear, the risk perception tool, further questions around incentives, and sort of how to increase referral rates and so forth. We'll have a look at all of that and come back to you. I will encourage you to sign up to the webinars that we have later in the month or next month on the 8th of March, nicotine in pregnancy, and that will coincide with the publication of some updated resources around e-cigarettes. And then the incentive schemes webinar on the 28th of March, where we'll go into much more detail around the role and the potential of incentive schemes to support pregnant women, and that will happen alongside publication of a new briefing around incentive schemes. And then we will be doing some more work later in the year, in April, looking specifically at health visitors and relapse prevention. So thank you so much to all of our speakers. I'm sorry that we didn't have time for more questions and that the technology didn't quite work all the time. But thank you to all of those that have listened through to the end, and again to our presenters. Thanks very much.